recording these. I'm putting them on YouTube. You guys can view them if you want. Some of these are great for just screen capture shots. I didn't have any mnemonics in the last one, but some of these have mnemonics, and they usually do. I don't think this one does either, actually. Okay, I've never seen a patient with this condition, so that gives you one clue. 73-year-old male, 3-week history of blurred vision and floaters. Anybody know what it is? Bilateral. Well, I mean, it does look like the choroid has something crazy going on, and we are talking about the choroid, but actually choroideremia is not even in this lecture. Isn't that funny? Okay, we'll get back to this, and that's the reason to keep on pressing on. Sometimes you look at OCT and it tells you the diagnosis, right? You see this one kind of says CSC in it. Sometimes it just has it written out. Okay, central serous, it's an idiopathic condition, meaning nobody knows what causes it, right? Typically characterized by well-circumscribed subretinal fluid accumulations, right? You can oftentimes have a PED in the superior half of the exudative retinal detachment. You can get whitish subretinal precipitates or fibrin sheets underneath the retina. I'll show you some pictures of this. Those are shed outer segments or fibrin. Occasionally you just get a PED, and I go, yeah, thank you. And I say, yeah, you might have CSR. Well, we had somebody who was like a pilot or something last week. This is at Wilford Hall, so it probably wasn't you guys. Although you guys rotated recently, so maybe it was you guys. Anyway, if I just see a little PD, I don't call it CSR unless I see some obvious evidence of previous activity, which I'll show you in the next slide. Anybody want to tell me what their visual symptoms usually are? Corsini. Any idea?
None.
Sometimes it's none. That's right. I'll give you that. Let's say they have subretinal fluid under their fovea. Pal, what do you think they might come in?
Decreased visual acuity.
Right, decreased vision. What else?
Like metamorphopsia.
Metamorphopsia, good.
Myopic shift.
Would you get a
Hyperopic shift.
Yep, hyperopic shift. Micropsia and color vision problems. Good, you guys got them all. Acute or chronic disease, or they say, I just finished my Flonase inhaler, and all of a sudden my vision got bad. Okay, sorry. Ophthalmologist joke. Okay, demographics, right? Almost always men. It says just men in the book, but I said, well, it's men greater than females. I forgot what my ratio was in our study, but it's like 5 to 1, male to female. 25 to 55 years of age. So it's all of us in this room, I think. You guys are getting younger all the time. Usually Caucasians, Asians, or Hispanics. It says rarely African Americans. I haven't seen that so much in my practice, but whatever. 2020 to 2200. And they can sometimes get paracentral scotomata. This is what kind of image?
red free.
It's not. That's a really good point. I don't have a red free right beside this one. A red free is the light you're shining in reflecting back. So anything that is shiny, like a mirror, is going to look shiny. And in this case, we don't see that the blood vessel shininess, you know, when you see this. So that, what you just said is I'm glad you said it, because that is the most common thing that we call this, and or do the reverse. This is autofluorescence. The other clue is your nerve is black unless they have drusen. So we're basically, there's no RPE. The vessels and the nerve are basically where either RPE is absent, that's the nerve, or it's being blocked by vessels. We don't have a lot of time to go into imaging. But what you see are what I call gravity-dependent distribution, or guttering. Old fluid that's tracking down. Okay, we'll come back to that. We really do have to fly. Associations with CSR. These are all in the book for the most part. I'm throwing in a little bit of extra information, which means that I shouldn't be. All I want you to know from this slide is if you stop steroids, 88 to 100% in these studies got better. Okay. And type A personality. It's real. Iannuzzi studied it as his AOS thesis. Not everybody has CSR is type A, but almost everybody is. What's type A mean? Competitive drive, sense of urgency, aggressive nature, hostile temperament. Everybody gets that way driving long enough in San Antonio. But if you notice that about yourself, don't take Flonase, right? Okay? Just remember that. If you have a friend or a loved one that takes Flonase, tell them to stop, unless they're really laid back. So somebody else did a personality study. All these characteristics are not flattering. High risk avoidance, greater restraint, less extravagance. Who wants to be like this? I mean, I tell my CSR patients they can go look at these lectures, but I mean, it might make them feel bad. And I really, it's the funniest thing, I'll tell you this briefly because I'm already running behind. I had a CSR patient of mine who's a psychiatrist or psychologist, I don't remember which, and we're talking about this, and I said, you're such a nice guy, you know, and this doesn't really apply to you, but most people CSR are type A. He goes, oh, I'm type A. I'm like, no, you're not. I've known you for like years, and I've treated him a couple times with PDT. He goes, oh, no, that's me. And I started listing off some of these things. He goes, me. And it was a funny thing. He has GERD. He's taken Flonase before. He's got sleep apnea, and he's very type A. And it just goes to show you, when you're an ophthalmologist, you get to see the nice side of patients. You don't really see that hard driving side. So probably most of my patients are type A. I don't know, but they're really nice type A people. I'm risk avoiding. Maybe I'm type A, or CSR prone. Pregnancy stress, Cushing's, all higher steroids, especially third trimester of pregnancy. Watch out for CSR. If you have a CSR patient that's a woman and she gets pregnant, got to watch her closely. Give her the Amsler grid. Check her frequently anyway. We don't know if treatment for GERD helps. Some people have done a study. I don't think it was helpful, but these are some studies where it's associated with it, GERD is. And obstructive sleep apnea, have to throw in, Chris Rodriguez is in my study, looking at claims data, but basically if you have CSR, you have a 2.7 times higher risk of having sleep apnea than somebody who doesn't, or than the average population in the DoD. And we had like 1 million people, 1.2 million people that we looked at. This wasn't DoD-wise, just USAF DoD. And then we broke it down females. Okay, they're only 1.8 times higher, and males 2.4 times higher. But still, I would send everybody for a sleep study. No doubt about it. All right, differential diagnosis. I'm not going to go into all of these. I'm just going to show them to you. But these are things that are important when you've got a patient in front of you. You need to think about optic pit. You need to think about CNV or AMD. You got to think about polypoidal choroidal vasculopathy. Look for polyps on your ICG. You should get ICGs on these guys, by the way. VKH, that one's really obvious. Uveal effusion, I would say pretty obvious. And Best disease, pretty obvious. PCV and AMD are the only ones I ever have. I see people getting mixed up. So we're going to talk about all these things real quick. I want you to see a lot of pictures before I lose my voice. Okay, so see how there's like this roundish thing right there, and then you got some yellow dots in there. When you see a curvilinear change in the coloration, you got to think subretinal fluid, or PED, but subretinal fluid is the first thing you should think of. PED sometimes won't do that. And if you see these little tiny yellow dots, those are subretinal precipitate. Sometimes they're white. Little outer segments not getting shed. This is like this kind of subretinal fibrosis in the nasal half of the macula, temporal half of the macula, got some RPE changes, right? This guy has it even worse. RPE metaplasia. In fact, when we first saw him, we didn't know he had CSR. This is before we were doing autofluorescence frequently. Now it seems obvious, but I've had this guy in a lecture for a long time. This one, I'll tell you what, some of these guys you look in, and especially the next one, you go, it looks normal. You don't have good stereopsis. They're blinking at you. They're type A, so you're not getting a good exam. This one, it seems obvious that there's a blister of subretinal fluid, but I think this guy or the next guy, I had trouble seeing it on my exam, and the fundus photo made it a lot more obvious, and then, of course, other imaging modalities. OCT, my favorite. Notice where the green line is on the left on the IR photo, right? And notice on the IR photo, it's a reflectance image, so you see the blood vessels shining back at you a little bit, even though the nerve's kind of blackish, actually. Okay, so really thick outer segments. We'll talk about that in a second. They're not getting phagocytosed. There's our arrow. This green line's higher, and look, there's a tiny baby PED, okay? And the book even says that. I was really impressed with the book saying that. So if you say that tiny PED, usually the superior half of the exudative retinal detachment, got to think CSR, but think other things as well. All right, let's focus in on this. Anybody know what this line is? It corresponds to these 5 green dots. Anybody? We got Dr. Croskery here. What's that?
Where are the dots?
Oh, sorry. Right hand of the screen.
Oh, okay.
Right side.
Fiber layer. Yep.
What did you say?
It's kind of like on these fiber layer there.
Okay, yeah. All right, good. Okay, I shouldn't have asked you. So this is the boundary between the OPL and the ONL. All right, you guys got it. Okay, what's this line? Anybody? All right, RPE broke. That's good. And this one is the IZ, right? You guys probably can't even see what these are showing up, but purple on the right, ellipsoid zone, yellow-ish, ELM, outer nuclear layer, blue is the OPL. So OPL is showing up really nicely because, look, the fovea is draped up above subretinal fluid. We don't have time to go into it, but there's a really, that's important to notice that's a normal anatomic variation. Doesn't mean there's anything wrong with it. And that little,
symmetric, too.
Yeah, it's usually symmetric. And then those 4 little dots represent the outer portion of the OPL that we talked about earlier. And these are the outer segments that have been shed but not phagocytosed. Okay. Moving along. Oh, and these little guys, cross grade. I don't know what these are. Do you know what these are? These little dots? They're probably something important. All right. Okay, this is I did not do EDI OCT nearly enough, so I looked through my images, and yeah, this guy has a thicker choroid than normal, 348 maybe, and then after treatment, or no, we didn't even treat him, it just went away, 333, still thick. Normal's probably 250, 280, something like that. Age dependent and refraction dependent choroidal thicknesses. We won't dwell on that. Lots of drusen, subretinal fluid, it's CSR. Drusen by its, not drusen, I'm sorry, those are PEDs. This is a big single PED by itself, been there for a long time, and don't know what it's due to. Probably CSR, but maybe not. Could be a lot of other things. So once you've got it chronically, you get intraretinal fluid accumulation, cystoid spaces, you get these little PEDs, these little other lines, maybe that's part of Brooks that's splitting off. Things are just looking kind of like they've been there for a long time. That fluid on that bottom right-hand image, underneath the retina on the right-hand side, it's like the outer nuclear layer is just kind of atrophied, and it just can't even fill in that gap. It's kind of subretinal fluid, but it's really just space that's being occupied, really. Okay, same patient. He got an acute exacerbation. This is the nice guy I was telling you about that told me he's type A. But I want you to notice this. This is his color fundus photo. You could tell there's some pigmentary changes. But when you pull up his autofluorescence, it's like, wow, how did I miss that? It seems so obvious now. But when you see guttering, when you see hypo-autofluorescent spaces that track down surrounded by hyper autofluorescent, you got to think there was something leaking fluid here. There's like somebody turned on a little spigot and it's just dripping. Now this can happen with a nevus, you can have a choroidal hemangioma, but that's not on our differential. We don't see a pigmented mass or a well circumscribed lesion. This is CSR, and this is one of the great uses of autofluorescence early in its heyday. It's still in its heyday, but okay, so now we see another patient, little blister of subretinal fluid, some little subretinal precipitates. On autofluorescence, it's hypo-autofluorescent. Why is that? Because that fluid is actually blocking the normal RPE fluorescence. Now, after that fluid's been there for a long time, you get a lot of shed outer segments that have fluorophores in them, A2E, lipofuscin, yummy. That starts to get hyper-autofluorescent, right? And you'll see that in other cases. This is the same guy as OCT. Hey, this is that one guy I told you about. We did autofluorescence on him, and that's where we're like, whoa, that's a big deal. And so this is guttering again. Could he have had a choroidal hemangioma under there? He could have, but he didn't. Look at that OCT. You're not going to make this person see better. You get rid of his fluid, well, you're not going to get rid of his fluid. If you stuck a needle in there, drained it, he's still not going to see better. Mueller cells have been ripped and shredded, and there's little grave tombstones all over the place for Mueller cells. Nobody's alive in there, and it's just, it can happen with any kind of chronic subretinal fluid. It just goes in, creates cystic spaces. The cystic spaces break the septae, then you have that. Okay, we're going to go into FA really quick. This is the best part of the whole lecture, in my opinion, or at least the CSR part. All right, little expansile dot, right? Yeah, okay. Now, this is that other image I showed you earlier where we drew CSC in it. This is that guy, fibrotic. Didn't know what his diagnosis was the first time around, and then we figured it out later. This kind of diffuse pattern, really nothing to get excited about, but that's the other category. And then the final category is smokestack. You guys been to Smoke Shack? It's awesome barbecue. It's really good. It's off of Broadway, close to Kitty Park, if you go there for kitty parties, hopefully with your kids. But look at this. This thing like spews all over the place. It doesn't just go one way. It's like, all right. So I had to re-modify this a few times a couple months ago. But look, now we got a movie for the expansile dot, a little movie for diffuse, a little movie for smokestack. Makes me think of Smoke Shack, and now I'm hungry. I really didn't get much sleep last night. I do very poorly. There's people who have genes that are like they're morning people or night people who've studied this. Night people do really well, even though they are grumpy in the morning. I'm kind of a morning person. I don't compensate well with lack of sleep. I was a terrible resident. Okay, so I'm about to say something with no filter. So, all right, and I was going to name names. So, okay, let's move along. All right, ICG, very important. You'll just have to read this slide later because we have to move on. We're already past time. Okay, I'm not sure why I have that up there. Lots of leakage, bright stuff. When you treat with PDT, you need to know the full dimension of the hyperpermeable choroid. This is where the whole problem is in CSC, is it's in the choroid. We don't know why it's there, but the choroid gets thicker, it gets, maybe we could say inflamed, and then it just pushes through. I don't know what that was. That was something really quick, but had some kind of, oh, here we go. It might be a GIF or something. I put this part together about a month and a half ago, and I didn't review it last night. I was taking out a brass foreign body out of somebody's eye. really interesting. He actually might do really well. Okay, so hyperpermeable, I treated this guy a few months ago, and his subretinal fluid went away within 4 to 6 weeks. And that's the case for most of these people with PDT, but I'm getting ahead of myself. Visual prognosis is good, except in chronic recurrent and bullous cases. Almost everybody's going to spontaneously reabsorb. Who knows what that includes for steroids? This is just from the book, back before even steroids were closely associated. Visual recovery lags SRF resorption. Makes sense, right? You got to get those outer segments reabsorbed after the fluid's gone. Then you got to get the ELM, and the ELM is usually still there, but the ellipsoid zone and the IZ have to kind of connoiter themselves. Half will have a recurrence. Got to remember that. Again, don't know what effect steroids have on those numbers. So your treatment options, nothing. Laser photocoagulation. This is from a 1974 study before I was born. Shortened subretinal fluid time from 23 to 5 weeks. You have to be judicious. You have to put. You can only. I've done it and it works great. But you're really kind of putting your finger in the dike in the little spot with it's open. You're not really treating the underlying issue as much as PDT is. PDT is actually thinning the choroid out a little bit with verteporfin. We use half dose or half fluence. I'm a half fluence guy. Am I? Yeah, I'm a half fluence guy. I've done half fluence and half dose. That was a one-time PDT, didn't work for me, so it doesn't really matter which one you do, stick with something. It reabsorbs fluid fast and decreased recurrences, except for my really nice type A patient. Okay, remember CNV can develop in CSR patients with or without laser photocoagulation intervention. So criteria, okay, so this is important. Subretinal fluid persists beyond 3 to 6 months. This is your first episode, right? Disease recurs in eyes with visual deficits from prior episodes. Makes sense. If you have history of it.
Your conference is scheduled to end in 10 minutes.
All right, great. Permanent visual defect or deficits present in the other eye from a prior episode, right? I would treat somebody who's got damage in their fellow eye. Chronic signs develop, so we're talking about intraretinal fluid cystic changes and RPE changes. And then if you're a pilot or you have occupational needs for stereopsis, like if one of us gets it, I would do PDT. I wouldn't want to do it, but we would just do it. PDT side effect profile is beautiful. It's really not that bad. And we actually have like 5 more things to talk about, so we're going to fly through it. You could get screenshots later if you want. Choroidal perfusion abnormalities. The book just goes, we have to talk about this stuff, but we really don't want to. They show a few pictures here and there. Malignant hypertension, eclampsia, cocaine can cause problems. I want you to see this image. It used to be on my mock oral boards. Maybe it'll be again this year. This is a 30-something-year-old guy. He's got discodemia. He's got FIPTSs. He's got cotton wool spots. He's got hemorrhages. He's got hard exudates. Other eyes the same. He used to have really great vision until a few days ago. You do his FA and you go, it's not really perfusing that well. Wow, the choroid's not getting all the blood supply that it needs, and I've got lots of other things going on. And then you check his blood pressure and find out it's through the roof. So you got to think about these things. This is a person with GCA. He's got a little ciliochoroidal vascular occlusion. He's count fingers. Why does he count fingers? This nasal thing wouldn't explain it. You do his FA. This is 20 seconds. This is 22 seconds. This is 26 seconds. His choroid's not getting blood supply, right? His retinal vasculature is getting some. Anyway, it's not pretty. But you see his fovea is really dark. It's almost like he has a Stargardt dark choroid because the choroid's not getting blood supply. Okay, so that patient GCA. That's bad. Treat him. 67-year-old decreased vision in the right eye for 3 days. That's not an artifact at the bottom of the screen. That's uveal effusion syndrome. Nanophthalmos, that's your ultrasound. Nanophthalmos transscleral aqueous outflow is decreased due to nanophthalmos scleritis idiopathic uveal effusion syndrome. If they're hyperopic, and that's mentioned in the question, it's probably relevant. That patient was like +7. You could treat his scleral windows or other things. Sometimes it's misdiagnosed as CSR. This is the patient with a choroidal hemangioma. I think this is Dave Kim's patient. This is the ICG. There's this classic washed out pattern. That's probably all you need to know about that. There it is. Nope, next one. Nope, next one. Washed out, right? Choroidal hemangioma is 2 categories. Circumscribed and diffuse. Circumscribed is reddish-orange, asymptomatic or blue vision due to hyperopic shift or ERD, washed out pattern on ICG. The diffuse has a washed out pattern too, I think. But Sturge-Weber, glaucoma, or amblyopia, they have this tomato catsup fundus. I can't even say catsup with a normal accent. Both types can lead to CME, exuded retinal detachment, epichoroidal membrane, never seen that with calcification. Treat these guys with PDT. Finally, back to this guy, 73-year-old, decreased vision for 3 weeks, 20/60 in both eyes. Anybody figured it out yet? Flashed up on the screen early, but didn't leave it there. hyperfluorescent little lesions, little subretinal fluid. That's Stratus. That's what I'll be using in Africa. I got 3 of those machines donated a couple weeks ago. Stoked. This is after treatment. Not much better. After treatment again. Okay. Ba-dump. B-dump. Bilateral diffuse uveal melanocytic proliferation. Still haven't seen this. Often heralds a systemic cancer. If you see weird stuff like this, you need to refer to retina. We'll try to figure it out. And then they have all these associated cancers. I don't think I'll test you on it. Ovaries, uterus, lung, and then colon, pancreas, gallbladder, and esophagus. That's supposed to say less commonly, but I think that's when I got the call from Dana Anderson to come in. I think that's it, guys. If you have questions, feel free to ask. These will be up on YouTube. If you go to youtube.com/Baskin, A-S-E, Baskinase, you'll get there, or just Google Baskin, whatever. Hopefully they'll be up there tonight if you want a screenshot. Thanks for your attention.